Welcome to Fertility Doc Talk. I'm your host, Dr. Kaajal Abrol. I'm a board-certified obstetrician-gynecologist and fertility physician based in Toronto, Canada. My goal is to educate patients, partners, and the public on fertility, and to destigmatize infertility. Through this podcast, I aim to increase knowledge and awareness about reproductive health to empower people to make informed decisions about their own fertility. Welcome, everyone. In this episode, we are talking about an important fertility topic, pregnancy loss. Pregnancy loss, often called a miscarriage, is generally defined as the loss of a pregnancy before 20 weeks gestation. Pregnancy loss is said to occur in as many as 1 in every 4 pregnancies. Many of these happen in the first trimester, the first 12 weeks of pregnancy, and are called an early pregnancy loss. There are a lot of terms that are used to describe non-viable pregnancies. First, let's talk about some of the medical terminology used often by healthcare providers. A common term used to describe a pregnancy loss up to 20 weeks is spontaneous abortion. This is different than a pregnancy that is terminated for medical or non-medical reasons, which is called a therapeutic abortion. When a pregnancy loss occurs very early, before ultrasound evidence of a pregnancy, it is often called a chemical pregnancy loss. This is because the pregnancy hormone levels in the blood rise, but then fall before the pregnancy has a chance to develop and be seen on ultrasound. When there is evidence of a pregnancy on ultrasound before a loss occurs, it is called a clinical pregnancy loss. Some other terms that have been used to describe a pregnancy loss, but are used less recently, include blighted ovum, which refers to a pregnancy that starts to develop but stops before a yolk sac or embryo are seen on ultrasound, so only a gestational sac is seen in the uterus, and missed abortion, which refers to a pregnancy with a visible embryo on ultrasound, but without cardiac activity, so no heartbeat is seen. This may also be called an embryonic demise. In these cases, the pregnancy loss is asymptomatic, so there has been no vaginal bleeding or pain. These are all very technical or clinical terms, and while they are important in diagnosing pregnancy loss and communicating ultrasound findings between clinicians, there have been studies showing that patients prefer terms like miscarriage or pregnancy loss rather than spontaneous abortion or pregnancy failure. There are several known causes for pregnancy loss. The most common cause of an early pregnancy loss is a chromosomal abnormality. Chromosomal abnormalities, meaning there is an abnormal number of chromosomes in the embryo and fetus, are said to cause about 50% of early pregnancy losses. Other factors that may lead to pregnancy loss include structural issues in the uterus that is carrying the pregnancy, injury or trauma, uncontrolled medical conditions in the individual carrying the pregnancy, and exposure to medications or drugs or toxic substances. Some potential risk factors for pregnancy loss include older age of the eggs, a prior pregnancy loss, significant caffeine intake, cigarette smoking, increased alcohol intake, and recreational drug use. Being significantly under or overweight can also increase the risk of a pregnancy loss. So now that we have reviewed the basics of what pregnancy loss is, the terminology, and the causes, let's talk about how it may be diagnosed and treated. The most common symptom of pregnancy loss is vaginal bleeding. In addition to this, it is common to experience abdominal pain or cramping. In order to diagnose pregnancy loss, a combination of blood tests and ultrasounds are often used. The blood tests measure the hormone human chorionic gonadotropin, specifically the beta chain of this hormone, so this test is often called a beta HCG level, or simply a beta. The ultrasound looks at the uterus to try and identify a developing pregnancy within the uterine cavity. Once a pregnancy loss is diagnosed, there are a few options for treatment. Sometimes the pregnancy tissue will leave the body on its own, so a conservative wait-and-watch approach may be okay. Other times, medication can be used to help encourage the uterus to contract and help pass the pregnancy tissue. And lastly, surgery is sometimes used to help remove the pregnancy tissue. Surgery may involve a gentle suction to help remove the pregnancy tissue, or what is called a dilatation and curettage, or D&C, where a metal instrument is used to gently scrape the walls of the uterus to try and remove the pregnancy tissue. It is important that a D&C be completed carefully to remove all the pregnancy tissue, but also gently to try and decrease the risk of scar tissue from developing within the uterus. With each of these options, there are pros and cons, so it's important to have a discussion with your healthcare provider to decide which option makes sense for you and your situation, and to understand some of the risks. For example, sometimes the wait-and-watch approach or the medication are not completely successful, and a D&C is later required to remove residual pregnancy tissue. Or, as mentioned, sometimes a D&C results in scar tissue, sometimes a little, other times quite a bit. Although these risks are low, it's important to be aware of them. Recurrent pregnancy loss, also called RPL, is an important topic related to pregnancy loss. I'll touch on this now briefly, but we will get back to this topic in a future episode of the podcast. Recurrent pregnancy loss now generally refers to 2 or more clinical pregnancy losses. Previous criteria for this used to be 3 consecutive early pregnancy losses, and this is still the definition in certain countries. Some of the causes for recurrent pregnancy loss include genetic issues like a balanced translocation, structural issues like a septum within the uterus, uncontrolled endocrine disorders like thyroid disease or diabetes, autoimmune issues such as antiphospholipid antibody syndrome, and clotting issues or thrombophilias. Additional factors that may play a role include ovarian aging, which increases the risk of chromosomal abnormalities, and sperm factor infertility, specifically related to high DNA fragmentation. It's important to see a fertility specialist and consider testing if you have had 2 clinical pregnancy losses. It's also important to be aware that in as much as 50 to 75% of cases, possibly more, an exact cause for the recurrent pregnancy loss is not found. That said, it's important to look for a cause and treat any underlying issues if possible. I'd like to take some time now to discuss ectopic pregnancy. An ectopic pregnancy is a pregnancy that implants outside of the uterus. Most commonly, this occurs in a fallopian tube, but it may also occur in other locations, like in the ovary or in the pelvis or abdomen. An ectopic pregnancy is not considered a miscarriage per se, but it cannot continue to develop and result in a live birth, so it is a non-viable pregnancy, and it's important to discuss it. Ectopic pregnancy is diagnosed with a combination of blood tests looking at the beta-HCG hormone and ultrasounds looking at the uterus and pelvis. With beta-HCG levels, it is common to see a beta which rises slowly or plateaus. With ultrasound, it can often take time to see a pregnancy developing outside of the uterus and may take more than one ultrasound exam to identify this. Abdominal or pelvic pain or vaginal bleeding can be symptoms of an ectopic pregnancy, although many are not symptomatic at all. The real concern with ectopic pregnancy is that it can become life-threatening. For example, if an ectopic pregnancy is located in a fallopian tube, and the fallopian tube ruptures as the ectopic pregnancy grows, this can lead to internal bleeding, so it needs to be treated urgently. For this reason, healthcare providers will follow patients closely when the beta-HCG hormone is not rising as expected, and will often consider an early ultrasound to see if an ectopic pregnancy can be identified. Treatment for an ectopic pregnancy often involves an injection of a medication called methotrexate, which stops cells from growing, and the pregnancy tissue is then absorbed by the body over a few weeks. Sometimes medication is not effective or safe. For example, when the pregnancy is a larger size or if it has already ruptured. In these cases, surgery is needed to treat the ectopic pregnancy. Surgery for an ectopic pregnancy that isn't a fallopian tube may involve removing the fallopian tube or possibly opening the tube and removing the pregnancy tissue alone. Now let's take some time to go through some common questions I hear about pregnancy loss so you can better understand it. First, what did I do to cause my miscarriage? It's important to know and understand that you did not do anything to cause your miscarriage. Most miscarriages are due to a genetic or chromosomal issue, something you did not cause. It's important to know that your past life choices or your stress levels did not cause a miscarriage, something that so many individuals worry and blame themselves for. Another common question I hear is, I just had a miscarriage. Is there a way to tell if it was caused by a genetic issue? Yes, there is testing that can sometimes be done to identify chromosomal issues in the pregnancy tissue. This requires collecting some of the pregnancy tissue, either after passing it on its own, or by using medications to help pass the tissue, or from a D&C sample, and then sending it to a specialized lab for testing. The last question I want to address is, I just had a miscarriage. Do I need to wait before trying to conceive? Years ago, the recommendation was to wait 3 months after a miscarriage to try and conceive. This is no longer the recommendation. Once your beta-HCG level has dropped to negative and you have had a normal menstrual period, you are able to start trying to conceive again. The one exception to this is when you are given methotrexate to treat an ectopic pregnancy. In this case, you must wait 3 months after the injection to try and conceive again. So there you have it, all about pregnancy loss. Pregnancy loss is an important topic to openly discuss. For so long, people have felt like they cannot talk about miscarriages. They have felt like they need to go through it alone, and that is not okay. I hope that by speaking about pregnancy loss, people can better understand what it is and how common it actually is. I want people who are pregnant and partners of people who are pregnant to be able to talk about miscarriage and their experiences, if they feel comfortable doing so they can get the support they need and deserve. Today's episode is a review of the medical side of pregnancy loss, but there is so much more to learn and to discuss, particularly about the emotional side and experience of miscarriage, and I hope to dive into that side of things in future episodes, so stay tuned. I hope this episode was useful in allowing you to better understand pregnancy loss, some of the causes, how it is diagnosed, and the various treatment options. That's it for this episode of Fertility Doc Talk. I really hope you enjoyed listening and learning and feel empowered about your reproductive health. If you enjoyed this episode, please remember to subscribe to the podcast and tune in to our next episode.